It is my pleasure to introduce our first speaker, Dr. Sharon Greene from the New York City Department of Health and Mental Hygiene and the Department of Epidemiology at Columbia University's Mailman School of Public Health. Dr. Greene began her academic career at the University of Chicago in biological sciences. She then made her way here to the University of Michigan School of Public Health, where she completed her MPH in hospital and molecular epidemiology and PhD in epidemiologic science under the advisement of Dr. Mark Wilson. From there, she completed her postdoctoral training as an Epidemic Intelligence Service Officer in the Enteric Diseases Epidemiology Branch at the CDC, conducting foodborne disease surveillance and outbreak investigations. Dr. Greene worked as a lecturer and principal research associate at Harvard's Department of Population Medicine, where she focused on near real-time vaccine safety surveillance, space-time scan statistics for syndromic surveillance, and trends in antiviral and antibiotic usage. Her current roles include serving as the lead epidemiologic consultant and director of the Data Analysis Unit at the Bureau of Communicable Disease Branch of the New York City Department of Health and Mental Hygiene. Her work here includes spatio-temporal cluster detection and data quality analyses for reportable diseases. Dr. Greene also holds an assistant professor position teaching courses on epidemiology, surveillance, and infectious diseases at Mailman School of Public Health. Along the way, she has been presented with a number of honors and awards, including the American Journal of Epidemiology Top 10 Articles of the Year for 2013, the International Society for Disease Surveillance Award for Outstanding Research Article in Biosurveillance, and most recently, the Presidential Priorities Award, presented by the Council of State and Territorial Epidemiologists for her work in the advancement of improved health outcomes using informatics. I'm sure we are all excited to hear her insight on the spatial-temporal analyses being conducted throughout New York City, so please join me in welcoming Dr. Sharon Greene.
It's a real honor to be here today. Thank you so much for including me. So let me begin by telling you a little bit about where I work in the Bureau of Communicable Disease at the New York City Health Department. Our mission is to rapidly recognize and respond to communicable disease threats to prevent or control ongoing disease transmission. Our Bureau is responsible for 72 reportable diseases, which have a broad range of modes of transmission and etiologic agents, so including the enteric and waterborne diseases, chronic hepatitis, et cetera. The newly emerging diseases, we are sort of the emergency department for this city. Our city does have some extreme vulnerability to communicable diseases, in part because of our demographics. We have a very large population, over 8.5 million residents, very densely populated, so a small geographic area. We have high rates of comorbidities, including HIV/AIDS, that can increase the risk of other communicable disease infections. Our environment also has some unique features. New York City has the largest unfiltered surface water supply in the country. Of course, New York City sees much international travel and commerce. We are a major US port of entry with about 22 million international passengers arriving each year. And unfortunately, we remain a potential terrorist target. So there's a list of reportable communicable diseases that are required by law to be reported to the New York City Health Department by healthcare providers and laboratories. And so here's the list. And because today's focus is on malaria, I'll note that one of the reportable diseases in New York City is malaria. Locally acquired mosquito-transmitted malaria most recently occurred in New York City not so long ago, in 1993, demonstrating the potential for reintroduction of malaria transmission into areas that are no longer endemic, and emphasizing the need for continued surveillance and prompt investigations if cases without risk factors are reported. We also had a healthcare-associated malaria transmission in 2012. That investigation concluded that malaria was transmitted at a hospital in the city through a breach in infection control precautions, perhaps through a lapse in glucometer cleaning and documentation, but the precise mechanism of that transmission is unknown. We routinely summarize our data. This is one of our agency publications called an EPID data brief. So we see that over this period, 2004 to 2012, all of our cases were travel associated. 2/3 of them were traveling for the reason to visit friends and relatives. 3/4 were traveling to West Africa, where they became infected. and almost 80% did not take any chemoprophylaxis before or during their travels. So this malaria has commonalities with other travel-associated diseases, including hepatitis A and typhoid in New York City, where we can target interventions, educational interventions, to the people who are most at risk if we take a close look at the data. So for New York City, we really want to encourage chemoprophylaxis use, particularly among West Africans living in the Bronx. We make our data available at annual temporal resolution. It's publicly available through this application called EpiQuery. And if we look at our cases of malaria from 2000 to 2017, 170 to 270 cases are reported each year. So in the most recent year, about 230 cases were reported for a crude rate of about 3 per 100,000. And if we look at how the cases are distributed throughout New York City, we see the highest rates are in a few neighborhoods in Manhattan and the Bronx here. And we can also see that there's increasing incidence with increasing neighborhood poverty, and I'll talk a bit more about this later. So today I'll be focusing on a variety of communicable diseases, including other vector-borne and imported diseases and methods that Mark has used throughout his career, a few of which he introduced me to. And we've applied these methods in ways that I think are exciting in a context that's local and domestic, but has potential implications elsewhere in the world. So back to the Bureau of Communicable Disease. One of our key activities is to perform routine and systematic analyses to track disease trends, characterize clinical and local epidemiologic features, identify exposures, risk factors, and population at risk, because we are responsible for targeting prevention efforts. So one of the technological advances that really enables us to do that work is real-time geocoding. GeoSupport Desktop Edition is prepared by the New York City Department of City Planning, and it's a highly customized geocoding package that allows users to practice our local geographic information. The disease surveillance database that we use is called MAVEN, and MAVEN is integrated with a web service for GeoSupport. So when a patient address comes in on a lab report, for example, MAVEN calls out to GeoSupport and results are returned in a machine-readable format. So this is an example, a screenshot from a part of our disease surveillance database. This is the address for Rikers Island, which is a large jail in New York City. And look at the richness of geographic information that we have for this case. So it's the X and Y coordinate, the latitude, longitude, indicators of which neighborhood this is. This is a unique building identification number. This gives the quality of the building, census block, tax block, census tract information, et cetera. So having this kind of geospatial information for nearly every reported case of communicable disease in New York City in near real time allows us to perform many types of analyses to support routine public health surveillance and emergency response activities. So I'll be sharing a few real-world examples of the applicability of selected spatio-temporal and spatial analysis methods for controlling infectious diseases, including detecting outbreaks, characterizing disparities, looking at poverty and other socially vulnerable populations, and identifying areas at risk of disease or importation. So first, I'll talk about our work of conducting daily outbreak detection. So perhaps you already have a sense that we have a great need for automated cluster detection in New York City. We are awash in data all of the time. So you know we have more than 70 reportable diseases, more than 8.5 million residents. We're receiving more than 1,000 reports every day, mostly through electronic laboratory reporting. So we need computers to help us figure out where should we be prioritizing our resources for case and outbreak investigations and response activities. So the particular statistical method that we're using for this work is called the prospective space-time permutation scan statistic. It's one of the probability models available in the StatScan software, which is freely downloadable from this website. Some nice features of this particular method are that it simultaneously tests for clusters of any size and duration at any location without imposing any restrictions. It requires only case data, no detailed underlying population denominators, and it accounts for purely spatial variation. So if there's a part of New York City that's consistently high or low in disease occurrence or diagnosis or reporting. That does not cause false signals. It also accounts for purely temporal patterns, so we don't get signals that are attributable purely to seasonal effects or to long-term secular trends or day-of-week effects. And it accounts for multiple testing of all the different potential space-time clusters that are being evaluated within any given analysis. So if you're less familiar with this method, to give you a heuristic sense of what it's doing, imagine each of these points are census tracts. And our question is, are there excess cases within any particular census tract or set of census tracts? So let's draw a circle around each census tract and ask, are there more cases observed than you would expect inside versus outside that circle? And we repeat by drawing all possible circles of varying radius up to a user-specified maximum centered on each census tract. So far I've described a purely spatial analysis, but we want to do a spatio-temporal analysis. So we add time as a vertical axis. Imagine we're creating space-time cylinders where the circular base represents space and the height represents time. So in each analysis, we're creating this multitude of space-time cylinders. And I'll refer you to this methods paper if you're interested in the details about how the most likely cylinder is identified and how inference is performed to determine statistical significance. So what we've done at the New York City Health Department is we have written a SAS program, which is published in the technical appendix of our paper. It generates these SAT-scan case and parameter files automatically, invokes SAT-scan in batch mode, reads the analysis results back into SAS for further processing and display, and generates these targeted notification emails and summary reports for clusters that exceed our recurrence interval threshold, meaning that they're statistically significant. And we've set this program to automatically run each morning using Microsoft Task Scheduler, and this has been in place since February 2014 for about 35 of our reportable diseases. So in the first year of this system's operation, we observed 28 unique signals across 15 diseases, which is not a large burden. Many aberration detection systems have a real problem with over-signaling, but this is not one of them. Not every signal was necessarily actionable, but for example, in 2015, New York City experienced the second largest community-acquired Legionnaire's disease outbreak ever documented in the US, and it was first detected by this automated outbreak detection system. This is the raw SAT-scan output that first detected this outbreak. So we detected it on July 17th of 2015. So we see from July 9th to July 16th, there were 8 cases in this set of census tracts. And this recurrence interval suggests that this was unlikely to occur by chance alone. So we automatically generate this figure, which depicts that list of census tracts. So we immediately know the spatial extent of the cluster, and we also output the individual line list of cases included in the cluster for rapid investigation. So that was the first alert, and additional cases were reported over subsequent days. Ultimately, there were 138 cases linked to this outbreak, and there was an extensive epidemiologic, environmental, and laboratory investigation by local, state, and federal partners. And ultimately, we identified and remediated the outbreak source, which was a cooling tower. So that example was from 2015, but this system is continuing to be very useful for us. This is an example from earlier this summer in July. So on July 10th, this automated SAT-scan analysis first detected a cluster of 7 patients with Legionnaire's disease, occurring starting July 2nd, and residing within a 1.5 kilometer radius of each other in Lower Washington Heights, which is this part of Manhattan. Rapid case investigations confirmed that it was a diagnosis of Legionnaire's disease. They were true confirmed cases, and it revealed no other common exposures other than living in the same part of New York City. And ultimately, 27 total cases were identified over subsequent days. So the next day after the cluster was detected, there was prompt evaluation and laboratory testing of all cooling towers in the area. And 2 days after that, so on July 13th, there was proactive remediation of the suspected source tower. And here's an excerpt from the press release. announcing that the health department had confirmed the source of this outbreak when the Legionella strain was found in one cooling tower that exactly matched the strain that was found in 6 of the patients who had positive Legionella cultures on respiratory specimens. So the rapid automated early outbreak detection helped. And just because today's focus is about malaria, it is unusual for us to get SAT-scan space-time cluster notifications for malaria, but it happens occasionally. We did receive one earlier this month. So on October 2nd, we see there were 7 observed cases in this part of the Bronx. This was a weaker signal. And indeed, because we routinely interview all of our cases, as you would expect, all 7 were travel-related. But I might suggest that this method could be applied in other settings with geospatial information available to detect new or unusual transmission foci. There are some challenges in conducting this automated real-time surveillance. Foremost is data quality. The data have to be up to date. So if there are any disease reports that are pending data entry at the time of analysis, so if we didn't receive it from electronic laboratory reporting, but from a telephone call or a fax report, that case may not have been entered and be available for analysis, and so that would make it harder to detect an outbreak. Our geographic resolution for this analysis is census tract, so we are requiring our cases to be successfully geocoded, which may not happen if there's a typo in the street address, or if the patient address is a PO box, or if they're homeless. So we have to try to clean the addresses the best that we can, and we also have to deduplicate our data because you could receive more than one report per case. We also face challenges from surveillance discontinuities. So mostly for enteric diseases, we face this challenge of adoption of culture-independent diagnostic testing by different laboratories serving different parts of the New York City population at different times. So that makes it harder to detect changes from baseline that are true versus a surveillance artifact. And there are some interpretation challenges. The clusters suggest only approximate spatial and temporal boundaries. They might include background cases or exclude outbreak-associated cases. So there's this critical role for the epidemiologist to do the investigation. But I am really proud of the system. I think we do this really well in New York City, and some of the keys to our outbreak detection success are a very strong informatics infrastructure. I've mentioned several times the importance of electronic laboratory reporting and this automated geocoding of case addresses. I also believe that the particular probability method that we're using is very powerful and effective. We're fortunate to have dedicated analysts who developed and now maintain the system. When we generate signals, we have knowledgeable epidemiologists who can interpret and act on them as appropriate. And when needed, we can draw on adequate outbreak investigation resources. So that was sort of our base outbreak detection system, but more recently we've introduced some interesting variations on the theme of using the space-time permutation scan statistic that I'd like to share a couple. One is using multiple addresses for a given patient. So normally when we get an electronic lab report, the address on that report is the patient's home address. But during routine case interviews, we can collect a patient's other addresses, including their work address. And so there's this option within SAT-scan that allows you to consider a case as observed inside a cluster if any of the patient's addresses fall within the cluster. So this feature allows us to more quickly and precisely identify clusters where people are exposed in locations other near where they live. Another interesting variation is this multi-focused cluster test, which we use to assess clustering of Legionnaire's disease cases centered around buildings with cooling towers. And this kind of investigation can be useful for prioritizing environmental sampling and to help identify the most likely cooling tower. So this depicts 2 cooling towers, A and B, that both tested positive by PFGE for the 2015 outbreak strain. But the multi-focused cluster test shows us that cases were clustered more strongly around cooling tower A, accounting for more of the cases, more of the outbreak period, and had a higher recurrence interval. And indeed, whole genome sequencing confirmed that only isolates from tower A were indistinguishable from patient isolates. So I thought this was a really nice example of cluster detection and GIS methods and laboratory evidence coming together to help solve an outbreak. And so it is working with Mark that first sparked my interest in spatio-temporal analysis, including the use of scan statistics, which I first applied for my master's thesis looking at viral meningitis in Michigan with Mark. And here I am on the day defending my dissertation, where we further explored patterns in space and time here for influenza mortality. So now I'd like to describe a different use of geocoded data for the purpose of characterizing disparities in reportable infectious diseases. So I'm sure you know that socioeconomic disparities are associated with differential morbidity and mortality for many conditions of public health importance, but the extent to which this may be true for a wide variety of reportable infectious diseases is not well described. So we can use area-based poverty measures, for example, defined using areas based on census tract or zip code, to define populations at increased risk for identifying and tracking disparities over time and for targeting prevention measures. So in this paper, our objective was to describe disparities across area-based poverty levels by systematically analyzing a large set of selected reportable communicable diseases. So for this analysis, we looked at 53 of the diseases that are reportable to us. The study period was from 2006 to 2013, and we chose the start of the study period in 2006 because that was the year that electronic lab reporting was mandated in New York City, so we believe that the data were more complete and less biased starting that year. And as you know, we geocoded the data to census tract of residents at time of report, and we applied the methods of the Public Health Disparities Geocoding Project, which are available from the Harvard School of Public Health website. We define neighborhood poverty according to the percent of census tract residents with incomes below the federal poverty level according to the American Community Survey. And the way that this is distributed in New York City in 2016, we had an estimated 8.5 million residents. The number of residents in the lowest poverty level was about 2.2 million, and in the highest poverty level was 2 million. But we had representation across all four of these poverty levels. So the disease that ended up being most strongly associated with residing in a high poverty area is called rickettsial pox. So here, this y-axis is the incidence rate, and the x-axis is these four poverty levels ranging from low poverty, less than 10% of the residents below the federal poverty threshold, up to very high poverty, 30% or more. So we see more or less this gradient, but much higher incidence in the highest poverty level. This is a disease that's transmitted to humans from mice via mites. So what we think here is that residents of the high poverty areas, given their housing conditions, likely have greater exposure to house mice. So that suggests some interventions that we can do now that we have this information. Another disease very strongly associated with residing in high poverty areas is chronic hepatitis C. So I should note that these cases represent cases that were newly reported during the study period and should not be interpreted as incident cases. And we believe that this association is driven by older age groups, particularly the baby boomer cohort, born 1945 to 1965, and by past injection drug use. In New York City, the prevalence of chronic hepatitis C is very high. It's our most common reportable disease within our bureau. We have a lot of efforts in place for strengthening prevention programs and linking people to care. And it's really exciting because curative treatment has relatively newly become available. So these are diseases that are amenable to public health intervention, and it helps to target and to know the populations that are at greatest risk. And malaria was actually the disease that was third most strongly associated with poverty in New York City. As you know, all cases were travel associated. The majority were infected while traveling to visit friends and relatives or before recently immigrating to the city. And this association with high poverty neighborhoods likely reflects immigration patterns, as patients in these areas may be less likely to access pre-travel health care, partly due to costs perhaps, but partly also due to the belief that prophylaxis may not be needed. So we would conclude, as has been concluded before, that prophylaxis should be promoted among at-risk travelers, especially those who are residing in these at-risk neighborhoods. Ultimately, there were 18 diseases that we identified to be significantly associated with residing in high poverty. Those diseases are shown here, sorted in descending order of the incidence rate ratio. So to interpret this, for example, for rickettsial pox, we see that residents in the highest poverty neighborhoods had 3.7 times the risk of being diagnosed with rickettsial pox compared with residents in the lower poverty neighborhoods. So you can see the wide variety of diseases that are strongly associated with high poverty. We also had 11 diseases that were significantly associated with residing in low poverty, and these are sorted in descending order of incidence rate ratio from the strongly protective towards the null association. And I'll just highlight these 4 diseases as being tick-borne. Of all of the diseases examined, it was human granulocytic anaplasmosis that had the most extreme disparity with this directionality. So the highest disease rate is in the lowest poverty area, and it falls off with this gradient. And we see a similar pattern for Lyme disease, very similar patterns also for babesiosis and ehrlichiosis. And as you might suspect, the explanation for this is it likely represents a population who has the resources to travel to areas outside of New York City where the infected vectors are prevalent. For an additional 12 of the diseases we examined, there was no significant association with poverty, and for another 12, the data were too sparse, fortunately, to determine one way or the other. But ultimately, of the 41 diseases that had adequate sample size, 44% were associated with high poverty, 27% with low, and we believe these are useful findings for next steps to focus the investigations on the subgroups or specific pathogen types that are at the highest risk, to guide programs to minimize inequities by targeting outreach or education, and also serving as a baseline for monitoring disparities over time in New York City and across jurisdictions. So now I'd like to describe an analysis to identify and resolve disparities in the midst of a public health emergency, which was the importation of Zika virus in 2016. So we in New York City were at very high risk for imported Zika, more than 8.5 million residents, almost 2 million of whom were born in Zika-affected countries from that year. We have a large travel volume, 6.5 million passengers from those areas. And because we have experience with imported dengue and chikungunya, we also expected high incidence of Zika. And for those diseases also, it was mostly from people who were traveling for the purpose of visiting friends and relatives. And ultimately, in 2016, our city accounted for more than 20% of all Zika cases nationwide. In January of 2016, we instituted screening for travel and sexual exposure to travels, and this was recommended for all pregnant women. And if they screened that they were exposed, then testing was recommended for all exposed pregnant women. It was really crucial to identify and test these women. Early diagnosis of Zika is important. The earlier you can test someone, the more likely that testing result is to be definitive. It's useful to have these results for monitoring pregnancy and for offering women the most complete information available for decision-making early in pregnancy. And if they do test positive, to rapidly identify, evaluate, and then test the infants who were born to these infected mothers. So in 2016, all Zika testing was performed in public health labs. You had to go through the health department. Patients had to meet very specific criteria, and we required a lot of information to approve and carry out the testing. So we needed to know if they traveled, the country or territory of travel, their pregnancy status, when they were going to deliver, the last possible date of exposure, be it travel or sexual exposure. We wanted to know their symptom status. If they were symptomatic, we wanted to know their onset date. And then if testing was ordered, all results, so both positive and negative test results, were imported to the surveillance system, and we had demographic data, including address. So again, this automatic geocoding of case information really came in useful. It was really burdensome for providers to order these tests. They had to call us by phone. It could not be done electronically. It took 10 to 15 minutes to order this test per patient. out of a busy healthcare provider's day. We also expected high rates of travel in communities who had larger numbers of persons who were born in the Zika-affected countries or territories, but we did not have access to actual travel data. So we know how many people arrive in airports, but we don't know whether those arriving passengers actually live in New York City, and if so, how they are distributed within the city. So in February 2016, pretty early in this response, we started to hear rumblings of suspected disparities. We noticed that there were high rates of testing from large OB practices that were serving the higher socioeconomic status, the neighborhoods that had few immigrants. And we heard anecdotal reports of low rates of screening and testing of pregnant women, especially in some public hospitals. So this map of New York City shows census tracts classified by the number of residents born in countries or territories with active Zika transmission. The darker green areas of the city have the most people born in those areas. Now on the right, we see the Zika testing rate for reproductive age women during January and February of 2016. It shows that we are seeing low or no testing in areas of the city where we would expect to see high testing. So, for example, this part of the city, this part of the city, this part of the city, you would expect to see high rates of testing, but you do not. You see no testing here. So this was of high concern. So we identified this disparity early on, and the health department mobilized a large response to ameliorate these disparities through public education, through provider outreach by issuing health alerts to encourage providers to order testing, holding conference calls with providers, physically visiting outreach teams in affected areas, so physically showing up at more than 190 doctors' offices to encourage testing, and then especially targeting outreach to hospitals, especially the public hospitals run by the city, that had a high number of deliveries to women who were born in these countries, but low observed testing. And we worked hard to reduce the barriers for testing by instituting electronic ordering so that you didn't have to call anymore. And we actually placed health department staff on site at these hospitals to help complete the test requests. Unfortunately, we were able to observe a resolution of these disparities. So this is the same map on the left as before, but now we see the cumulative testing rate from January through September 2016, and we have filled in the testing rate in the parts of the cities that initially had under testing. And another way to look at this is the average monthly Zika testing rate for 100,000 reproductive age women broken into 3 time periods. So in January, February, the highest testing rate was in the lowest quartile of census tracts according to the number of immigrants from these Zika-affected countries. So what a stark gradient this is. In March through May, it evened out, and in June and July, it reversed. So now we see appropriately much higher testing in these parts of the city that have large numbers of immigrants from these Zika-affected countries. And finally, this is a larger geographic resolution looking at a neighborhood instead of a small census tract, but this is to show the incidence. So as opposed to the testing rate, this is the actual incidence, the people who tested positive. And as you would expect, even though there was lots of testing in these higher socioeconomic parts of the city, the incidence was truly very low. As we suspected, the incidence was highest in these neighborhoods that have the largest numbers of immigrants from these areas. So we concluded that communities with these large immigrant populations and also higher poverty levels were at highest risk for imported Zika. And analysis and mapping of these geocoded testing data revealed disparities rapidly during the first few months of the Zika response in New York City. And we actually used the data to target interventions. And thankfully, the disparities resolved following those interventions. And it shows that health departments can analyze surveillance data in real time to identify disparities and work to ameliorate them, even during a crisis, even during an emergency response. And so to tie this back to our honoree for today, this sampling of papers ranging from 1985 to 2017 demonstrate Mark's longstanding commitment to health equity and to exploring health disparities related to social determinants, including poverty and other markers of disadvantage. So I like to see this as a continuation of Mark's work. And just finally and briefly, I'd like to share some work that we did to identify areas at greatest risk for recent Zika importation, which was a very challenging project for me, given that spatially biased Zika case ascertainment that I described. So we were acting on very incomplete and spatially biased information. And we had no data on the population at risk, who was the travelers. So we did not know how they were spatially distributed within the city of these people who were arriving from Zika-affected countries. And so it was important to know where the imported cases were to detect and minimize the risk of local mosquito-borne Zika transmission. So that risk was low, and I'll give you the spoiler now. We did not have any local Zika transmission from mosquitoes, but this would have been a public health emergency, and it was a high concern for the health department. So this project was to support that work. So for this, we did nowcasting, and if you haven't heard that term, it's forecasting, but for the present, in the absence of complete data. What we ended up doing was a statistical model. We used logistic regression, where the study population was census tracts that had any Zika testing in the prior month. The outcome was presence-absence of any Zika cases in the prior month. The independent variables were 8 covariates from static sociodemographic census data, such as the numbers of immigrants from the Zika-affected countries, and also we pulled in the latest available surveillance data, and we ran this model weekly during the summer of 2016. And it was difficult to tell how well the model was working, but we identified weeks where the model at least discriminated better than random between census tracts that did or did not have recent cases. We used a ROC contrast test for that purpose, and if that test was significant, we went ahead and output and visualized the model predicted individual probabilities for all census tracts in the city, even those with no recent testing. So, by mapping this nowcast output, we visualized shifts in the spatial distribution of risk over time. So this shows the nowcast of the top 10% of census tracts at highest risk for importation as of 4 time points in June, July, August, and September 2016. For instance, as of late June, the greatest risk of Zika importation was concentrated here, which is the Bronx and Upper Manhattan. And in contrast, by August, the area at greatest risk had largely shifted down here to eastern Brooklyn. So we believe that this type of shift might reflect changing outbreak dynamics where the force of infection was peaking in different source countries at different times. So different subpopulations of arriving travelers who live in geographically distinct communities were affected at different times, and this could have changed the geographic distribution of imported Zika cases. So we use this modeled output to guide geographically targeted activities for detecting and minimizing the risk of local mosquito-borne Zika transmission. So knowing where the imported cases resided helped us for public education. It helps us to know which healthcare facilities we should be enrolling in sentinel surveillance for detecting local Zika transmission. If we received syndromic surveillance signals, for example, looking at emergency department chief complaints of fever and rash. So if it suggested possible Zika-like illness, we could overlay that with where we think the cases most likely are and to help us interpret whether that was actionable. And critically, I haven't spent much time today talking about the vector surveillance work of the health department, but we were able to overlay this human case data with the mosquito surveillance data for guiding control of, we have Aedes albopictus in New York City, which was a unlikely but possible vector of Zika. So having this output helped us to guide where the traps for mosquito surveillance should be tested and where mosquito control activities were most needed. This figure shows the 52 permanent mosquito trap locations that were in place during 2016, and this is a modeled output of where the mosquitoes most likely were for Aedes albopictus. And fortunately, you see that if you recall where the cases were, there's not a lot of overlap. So the strongest presence of these mosquitoes was in Staten Island, which is here, and you'll recall that most of the cases were in these other parts of the city. So there was some overlap here, but it was not as strong as it would have been if the cases were in Staten Island. So this was useful for us to know. I work in the Bureau of Communicable Disease, but in our environmental surveillance partners, they do a lot of work to survey and monitor, to surveil and monitor the mosquito populations and to conduct mosquito control activities as warranted throughout the summer, every summer, for West Nile and for Zika. So maybe some of you are students who are interested in the type of work described here. Maybe you're interested in working for the New York City Health Department, so I thought I'd just share how you can do that. If you are not interested in New York City, perhaps you're interested in working in other state or local health departments, I would really encourage you to consider that career path. If you want to be a direct hire by the health department, here's our website. We do offer a couple student internships called the Epi Scholars Program or the Health Research Training Program. So please check out our website and apply if you're interested. There are a couple other ways to work at the health department without being a direct New York City employee. And so they have separate job sites that you can look at. And just as I'm a proud alumna of this epidemiology department, I am also a proud alumna of the Epidemic Intelligence Service, so I will also give a plug. If you're interested in joining CDC's Disease Detectives, I'm happy to talk to you over the break about my experience, which was very positive. So if you're less familiar with this program, it's 2 years of on-the-job learning and fieldwork. You're guided by CDC experts, and you work as part of interdisciplinary teams to detect and respond to new and ongoing public health threats. If you think of a major public health event or emergency since the program was founded in 1951, EIS officers were there to investigate and respond. Currently, officers are placed at CDC headquarters in Atlanta, at field stations in Alaska and in Fort Collins, Colorado, and in 28 states, and in DC and US Virgin Islands. I get to be a secondary supervisor for one of the New York City EIS officers, and I really enjoy it. So field officers are placed, they're embedded in state and local health departments where they work side by side with local public health staff. So this is great training for fieldwork and applied epidemiology. So here's the website and email address if you want more information. So just in closing, for those of you who don't know, I have the good fortune of being married to our next speaker in this program. We were both students when we met in Mark's lab, and a few years later, we were really honored that Mark agreed to officiate our wedding legally. This was he actually was legally solemnized by the state of Massachusetts to perform our wedding. This was not just a show. So here he is signing the legal paperwork. And here he is performing our wedding ceremony. So I'd like to thank Mark for launching us in our professional and personal lives. Yeah, so I'll take any questions now. Thank you. Yes, you.
So your mapping software does a great job of analyzing places that are close in space, but I can imagine in New York City there are places that aren't necessarily close in space but are close in contact because there's such a great system of public transit. So you guys, that's not so important for environmental determinants like water cooling towers, but it might be important for communicable diseases. Is there a way to incorporate that in as a third access, or is that something you're thinking about?
Yeah, such a good question. Yes, so you can define, when we define space, in the analysis that I described, we assign cases to the centroids of their census tract of residence. You can also use other kinds of matrices to define spatial adjacencies. So you can define it along a transportation network. So imagine one row per census tract, and then you would list all the census tracts that you would define as near in any definition of near. So it doesn't have to be geographic proximity, it could be transit proximity. So there is a way in StatScan to define the coordinate file, not according to X and Y coordinates of census tract centroids, but according to this alternative specification. We have not set it up in practice sort of with the hope that you would see sort of a weaker signal. Like it shouldn't, we would hope that if it was geographically dispersed, that one of our purely temporal analyses that I didn't describe today might pick it up, or that it would pick up as simultaneous spatio-temporal clusters of smaller magnitude that we could then do the epi investigation and link together. Thank you. Dr. Kumon.
It's really inspiring to see that there's such a great public health practice of epidemiology that New York City is doing. New York City used to be a top destination for our externships, and then they cut off the externships from Michigan. sort of indicated that they might be available again.
Yeah.
Is that the case?
It is, yeah. I checked, I wanted to be sure I was accurate, so I checked the website before speaking, and I think it lists health departments where they accept students, maybe not for both of the programs necessarily, but I know for at least one of them, I think it explicitly says Michigan students are welcome to apply.
Yeah, there was a period when they only expected it
From the
a
local,
certain set of local institutions.
yeah. Well, I don't think that's currently the case. And I apologize for my predecessors. Who said that.
Thanks very much. I was wondering if you could go back to slide 58, which is really a spectacular slide. And so you're showing how, because of movement from different countries to different parts of the city, that corresponded to transmission back in the
Source
countries
countries.
where the travelers were coming from. So it's a beautiful map and beautiful investigation. But can you describe how the city was able to, how the health department was able to shift resources, shift personnel, shift focus to those different parts of the city in response?
Yeah, so it was sort of different kinds of response activities were relevant at different times. So for example, when we were setting up this Sentinel surveillance system, we were mostly focused on where the cases, human cases were distributed at the time the system was set up, and it wasn't an ongoing enrollment. So once that was decided, this was taken into account and then not revisited. But every week we would overlay with the mosquito surveillance data. So we would notice as the cases shifted from here to here, but in both examples, this did not overlay very strongly with where the mosquitoes were. So that was sort of the key thing. So if there was a strong overlap, then we would have targeted those areas for more mosquito surveillance and control, and for more education of the people who were living in those areas that they were like most at risk and should avoid prolonged periods of exposure for mosquitoes, because like it was really important to not have any mosquito-borne Zika in New York City. That would have been really bad. Does that help? Okay.
I'm interested in the mosquito surveillance and much about, I don't know, I'm not really familiar with it at all and how they interact with like the building structure and the layout of the city. Where there are very tall buildings, do you see many mosquitoes, or is it more where there's green spaces?
So, so the largest population density is in Manhattan, and there are very few CHAP sites there. I think this is Central Park, where there would not be the tall buildings right there. So I don't think that, I'll ask Justin to correct me if you think there would be large mosquito populations in the concrete jungle. It's less there. So these are more in the greener parts of the city, which do exist, which I wasn't really familiar with before I moved to the city. Like we do have green spaces. So that's where the CHAP sites are more located. Yeah.
Thank you very much.
Thank you.